welcome to Midway Specialty Care. Today, in memory of HIV Awareness Day for Women and Girls, I have my colleagues, Dr. Bertamaria Dieguez and Dr. Cynthia Rivera, to discuss issues around women and girls, particularly in our community, which is Miami-Dade County in Florida. First question will go to Dr. Rivera. Dr. Rivera, what are some of the challenges that women and girls face in terms of HIV awareness and prevention with respect to men?
Okay. So thank you for that question. I think I speak for all of us at this table that we as infectious disease providers in Miami-Dade County are quite interested in equity with respect to treatment of women, prevention of HIV and treatment of HIV. And I think one thing we've encountered in that journey is it's a lot of focus on women in their childbearing years, in a focus on contraception, and therefore a lot of the women's health goes to an obstetrics and gynecology practice, which has a lot of other issues, breast health, as I mentioned, contraception, and sometimes the conversation about one's risk for acquiring HIV is not as much of a priority as we would like it to be, particularly in a county like Miami-Dade. So I think that's the biggest issue. There's also, I think, on the provider side, perhaps less of a priority as well of bringing up taking sexual histories, really seeing how we can mitigate risk both from barrier methods of contraception, female condoms, male condoms, but also what's available as far as pre-exposure prophylaxis. And it's not often that these women come to specialty care clinics such as ours to have these conversations. So I think we're just at the tip of the iceberg when it comes to really educating and informing women about their risk.
Thank you for that answer. We know that in Miami-Dade County, in the most recent year, women between the ages of mid-30s are the ones who are acquiring new HIV infections. This is a slight shift from the years before when it was actually women over 50. So Dr. Dieguez, what do you see in your practice as new women, new cases of HIV coming into the practice?
So I would say within this demographic, specifically women in their 30s, we are unfortunately seeing these women newly diagnosed with HIV from their spouses a lot of the time. New relationships, a lot of these newly diagnosed patients that don't sometimes even know where they acquired the disease from as far as looking back at their sexual history. So I think there's a lot of factors at play because we are seeing an increased risk in this specific population, this age group. Obviously there is generational changes. Women are getting married maybe a little later. They're having more sexual partners. They are kind of, unfortunately, not using as much contraception as one would want, as Dr. Rivera mentioned. Their primary care doctor ends up being more or less their OBGYN, and the OBGYNs are not really having conversations with these patients. So, what I would say is that because of the generational shift in women, I think that is why we're seeing this specific age group, women in their 30s, being newly diagnosed. And so that's what I would say from here.
I think it's interesting to note also that for new cases of HIV in women, 98% of the women acquire HIV from sexual partners, not from drug use,
Right.
and not from being born with HIV as we would think about 30 years ago or 25 years ago at the height of this epidemic. I have another question for Dr. Rivera. What are some of the common misconceptions about how women acquire HIV?
Where do I start? One major misconception, I think, is the perception of risk. And I think this is not just the patient, I think it's also the providers. But when we look at the data and we look at the fact that of heterosexual transmission, 2/3 of those who acquire HIV who identify as heterosexual are women. Women are by default receptive partners. This is vaginal sex, but this is also anal sex, anal receptive intercourse to avoid pregnancies, for example, in certain age groups of childbearing age where the risk is high. And then you add that to the prevalence. If we look at 2022 data and you see the prevalence in Miami-Dade County and in Broward County for HIV, and then you see that 25% of those are women, or approaching 25%. It's about 23%. We need to step back and really see where we're missing the opportunities to have those conversations. And maybe those conversations are best had outside of a physician's office, of a healthcare setting. And so we're just looking for opportunities to dispel those myths, really share those risks, but in a very positive way, in a way where we are encouraging women to know how they can prevent HIV transmission, sexually transmitted infection transmission, and still have happy and healthy sex lives.
What kinds of, and this question is for Dr. Dieguez, what kinds of partnerships do you think would be helpful in bringing realistic risk assessment to women, especially the women that we're talking about, the women that are at highest risk for new HIV infection?
So I think, at least here in Miami-Dade County, I think there's, like Dr. Rivera mentioned, you have to think maybe sometimes out of the box, that it's not necessarily your healthcare provider that's going to give you information on pre-exposure prophylaxis or on condom usage or on educating general things that, maybe there's certain women that don't understand how they can get HIV. So, there's certain studies that are exploring this. There was a recent pilot study out of the New England Journal of Medicine recently published on how, in the South, the highest, Black women specifically are at the highest risk group for HIV. And so this pilot study pretty much used beauty salons, beauty parlors, and stylists as like the vehicle to discuss how to provide pre-exposure prophylaxis just by education, by handing out pamphlets and just speaking to their clients. And I think that's something that has really opened up a lot of people's eyes at how we deliver the information towards women and how women understand their risk, specifically in that population. So I think, we have to think outside of the box as far as how to deliver this information. Beauty parlors, obviously physicians, providers, but things such as even school counselors in college, things like that will mitigate the risk, hopefully.
Yeah, it's interesting too to note that in Miami-Dade County, 54% of the cases of HIV in women in 2022 were in Black women. So that's, and Hispanic women are also disproportionately at risk. Not as in an extreme, in the extreme as Black women, but yes, women of color seem to be more likely to be adversely affected by this kind of situation. So what can we do as healthcare providers, as women who are interested in providing preventive care for HIV and also treatment of women who are already infected? What can we do to improve the way that we practice? And that's open to either one.
So I think when we, what I've noticed that I started doing is when I have a woman come in, really get curious about how she learned about us, and encourage referral of other women to the office. But also I take a bit of an informal survey, what would have been a great way for you to learn about this? And I think answers such as beauty parlors, hair salons, are really helpful in that they are places where communities of women gather. And that's always been really helpful for me to ask those questions. We have also participated in support networks of women who are HIV positive to really engage in our local communities and let them know that we are a place where you can access care or testing the same day without needing an appointment. It's also going to be a matter of physicians of different specialties dialoguing with each other. So I think one thing that we've been doing is speaking with OBGYNs, speaking with primary care providers with a clear understanding that the pressures in both of those specialties and the demands are quite high, and just seeing how we can work together and have that collegiality for educating patients. But it's really about knowing what's available in the community.
Anything to add, Dr. Dieguez?
So I think, one thing I try and do, and I kind of even speak to some of my OBGYN colleagues related to this, is do not be scared to discuss sexual history with your patient.
Yeah.
Speak to them. Do not make them feel kind of less than. So I know that specifically in the Hispanic community, there's this, stigma of being, in all communities really, of being, how should I say this, promiscuous as a female. And I feel that there are certain experiences that a lot of my patients have discussed with me where they've made to feel kind of ashamed and to feel less than because they have multiple sexual partners. And, again, I think that's something that needs to be reiterated. I mean, even starting from medical school, the medical students, you have to be so comfortable to discuss sexual history with any and all patients, but specifically, women. And I think that will kind of mitigate risk and give us so much more information on each individual patient. So that would be like my, definitely.
Yes, I would say, that's a big factor. A man with multiple sexual partners is a stud. A woman with multiple sexual partners is a slut.
Yep.
So that kind of approach and that kind of opinion and ethos needs to be weeded out of how we interact with patients on a daily basis. There are some issues that come along now with the impact of sexual violence, either in a domestic setting or outside. I know that there are so many instances now where people are concerned, and we should be deeply concerned about human trafficking.
Yes.
And can you speak to how do we identify women who may be in that situation where they're in a situation of sexual violence, either in the home or maybe in another type of social situation? Dr. Rivera, you want to start?
That's a difficult one, and it's so prevalent that it's actually become a part of our generalized education for licensure, just because of the sheer prevalence of human trafficking. And I think women are disproportionately, I think it's safe to say, disproportionately affected by this. If possible, having a policy or at least letting people know that come with partners or spouses, if there's a suspicion, or maybe as a general policy of having individual discussions with patients, may help isolate or be able to help us engage with patients of, do you feel safe discussing these things in front of your partner? Are you in a safe space right now? Asking the questions to be able to provide assistance for someone who may be being trafficked. If that's not available, sometimes there can be signage in the restrooms for the patients so that they can go utilize the restroom, or they can even be motioned to go there to receive information on how they can seek help. From the broader perspective of HIV transmission, I think the biggest concern is that the ability to negotiate things like pre-exposure prophylaxis or barrier methods of contraception really is not available. And so therefore, our role as providers really becomes one of making safety a priority, so that we can then help them negotiate on the priorities needs. Safety really becomes paramount at that point.
Absolutely. So something that I do in my practice, and it's something like that I start assessing the minute the patient walks through the door, and kind of something that I end up doing is I do not allow the partner in the room. And that's something that I try and stick very clearly to. And then if I see that there's any hesitance whatsoever, I already have kind of focus and kind of attention. I think that's kind of like a red flag, right? Sometimes you'll see patients that their partner has to be in the room with them. And so that already you start to kind of wonder and think. And then as an infectious disease doctor, obviously, you talk about the risks involved, and you speak to your patient if you can get them alone. On, do you feel safe, X, Y, and Z, or even having pamphlets inside, like, Dr. Rivera mentioned, pamphlets inside private spaces in the waiting room while you're, charting or waiting to see the patient. They could be in the room and take down a phone number of, a halfway house or a shelter, something that can get them into a safe space. So I think, when it comes to violence and human trafficking, and again, there's so many types of, there's domestic violence, but then there's like these other pressures that unfortunately women suffer from through relationships, such as financial burdens, financial ties, that you have to stay with your partner for certain, survival, right? Yeah. You don't work.
Or have shelter, perhaps,
right.
Food.
You have small children, right?
Yeah.
And so these are all things you kind of have to, mitigate the risks with each patient and see how you can help them at the end of the day. It's very difficult. It's very difficult in these situations.
So I'd like to take the discussion in the direction of prevention briefly, because one of the things that we know about women who find themselves in situations where they don't have agency to ask for barrier protection, let's say, or they may be in a situation where they don't have ready access to a clinic. How can we help women prevent HIV infection if they happen to be in a situation like that?
Aptitude. I'm going to say one word: aptitude, right? And it's an injectable. It's something that we are using. It's not a pill. They can hide it.
Well, we can't say branding.
Sorry, excuse me. I'm so sorry. So a long-acting injectable is available.
Yes.
For women, and you don't need to have a pill bottle at home. You can, hide it. You don't have to. You don't have to kind of. You could say, I'm going to a doctor's appointment, and kind of, have that as an option through long-acting injectable therapy for females. And you'd be surprised how many OBGYNs are not aware of that indication for long-acting injectables for cis females as a prevention method for HIV. And so these specific women in these situations where, again, it may be trafficking, it may be domestic violence, it may be a financial abuse of power, they can't leave. How do they protect themselves? They could use these long-acting injectables if they are suspicious of their partner.
And that would also work for women who find themselves in commercial sex work.
Definitely.
To take at least steps to protect yourself in those circumstances.
I have some patients, and oddly enough, during the pandemic, it was interesting. During the pandemic, a lot of women who worked in entertainment, they ended up having to kind of, to survive, move to sex work. And so during that time, I really mitigated the risk. And there was a couple of them that I was able to get them on, PrEP. And they're definitely...
So for the audience, we mentioned PrEP. So you want to give a definition of PrEP for the people who are not familiar with that terminology?
Sure. So PrEP is our abbreviation for pre-exposure prophylaxis. And, I think many of us think of that in terms of pharmaceuticals. And in fact, there is a long-acting injectable available along with oral options. But pre-exposure prophylaxis is really an umbrella that encompasses testing for other sexually transmitted infections. We know on average things like gonorrhea, chlamydia, syphilis, herpes really increase inflammation and the risk of acquiring HIV every time one has sexual intercourse. So testing and treating other sexually transmitted infections is really a big part of what we do with pre-exposure prophylaxis, in addition to medication and frequent testing for both HIV and these other infections.
I think I'd like to switch the conversation a little bit now to treatment. We do know that in Miami-Dade County, for instance, there are somewhere between 40 and 42 per 100,000 people who are infected, and many of those people don't even know it. So as part of prevention, we lean on treatment and to get people into care. So I'd like to talk a little bit about bringing people into care and some of the roles that other providers may play in referring people who may be infected or actually identifying infections in people who may not know they're at risk.
So I think some definitely providers, they've been mentioned before, OBGYN, primary care, general screening places, Planned Parenthood, places like that are definitely somewhere where you want to get involved. Other places such as halfway houses, shelters, women's shelters are definitely somewhere where you really want to, have a firm presence to get these women into care, because there are so many of these patients that are out there outside of care. And so I think I read a statistic within Miami-Dade County, close to 12,000 Black females are PWHs out of care, and something around 7,000 Hispanic females are PWHs out of care. So,
so persons living with HIV.
PWH persons with HIV. Where are they? We need to find them. We need to identify them. So these are the places where you can kind of, see if the people that visit these places, if these are the 12,000, 7,000 people.
So one of the things I've noticed in my career is that in the minority communities, there are a lot of preconceived ideas about HIV and treatment. In the early days, people would say, oh, well, Magic Johnson, he's getting something special. That's not available to me. There's no good medicine for me. Or you may have heard this in your practice. Yeah, I knew this person who I don't want to take those pills because I knew somebody who took those pills and then they died.
Right.
Yeah.
So how do we break through for people who are already infected to say, listen, it's not something we can cure, but this is something that we can manage and you can have a normal life or a relatively normal life?
I think that starts with assessing sometimes the hesitancy to take medication may be due to those preconceived notions, and I hear those preconceived notions about side effects to medications, family members that have passed while taking medications in the past. But sometimes it has to do with the shame that a patient carries with being diagnosed in the first place, or a reminder of a sexual trauma that led to the diagnosis. So I think it's really important to individualize where the resistance is coming from. And then once we get to that root cause, particularly with women, Dr. Dieguez mentioned, and I agree 100%, a lot of women are transmitted from people that they trusted, spouses. The pain of that, the pill can be a daily reminder. And so sometimes, having other options like we now have with a long-acting injectable for that segment of the population who doesn't want to be reminded on a daily basis, that's helpful. But then I also get into, in today's day and age, just how incredibly safe and well-tolerated medications are. And one big thing is when we have somebody in our care not letting them leave our care without immediate access to medication and clear follow-up to say, listen, take this for 2 weeks and come see me in 2 weeks. Take this for 4 weeks and come see me in 4 weeks. And if you have any side effects, call me right away and we'll put you on something that you have no side effects. And in today's day and age, that's a very safe statement to say with the tolerability that we're seeing. So I think a lot of hand holding, and I mean that in a really nice way, like frequent follow-ups. Outreach teams that ensure that you're doing well or ensure that we are removing barriers to access to the medications, assistance from specialty pharmacies. We've been able to really engage people in their care and have people that have been hesitant to take medications for years really excited about how they feel on medications.
So if I can add something to that, I think something that I've been noticing more and more lately, and this goes with like throughout all generations, is a general mistrust of the medical community, unfortunately.
Yeah.
Specifically, historically, with minority populations, Blacks specifically, and Hispanics as well. And I think education. I think I've done things that I've even had to occasionally. I've done this actually 2 or 3 times, and it works exquisitely with patients that are very hesitant on starting medication. I will start the medication in my office, literally pill to the mouth, and I wait with them for 30 minutes. A lot of hand holding, a lot of observations, so they don't feel alone when they begin this therapy. And a lot of them are fearful of the side effects. Something's going to happen to them the minute they start their medication. So, we kind of eliminate that just by being present and watching them. It's as simple as that. And I've noticed every time I've done that, the patients are more than likely will be compliant with their meds. So that's a good strategy to kind of.
I think another thing for women and girls who already have HIV is to understand the concept of undetectable equals untransmissible. And I think that's very important for people to understand, that people who are of childbearing age may be worried that, I have this, I'm taking medicine, but what if I gave it to my kid, or have fears about transmitting to a partner who is not already infected. And now, if we know that if you are undetectable, meaning that virus cannot be detected by a lab test in your blood, that you will not transmit this disease to a loved one, whether that be your partner or whether that be a child that you may be looking to carry. And I'm proud to say that in my career, I've had many women have children, and they are all healthy and doing well because you equals you. Any other comments or pearls of wisdom that you ladies would like to pass on? What about for women physicians? Like, what kind of role should women physicians look to play in HIV, women and girls, prevention, treatment, and just general well-being? I know, Dr. Rivera, you have a lot of interest in wellness.
Absolutely. And I think HIV care for women is the very definition of bringing equity back into the space, the intersectionality of things that we see, differences of treatment based on gender, institutionalized racism. In the setting of HIV care, we can really knock down a lot of those barriers, really get into difficult conversations that we've been having, like human trafficking and the impact that is disproportionately on women, transactional sex. How can we be allies as female physicians to our sisters, our cisgender and transgender women who are suffering with all of these barriers to care, and just partner with them? I think it's so important to center their voices in what is needed in their communities for us to learn from, and that's going to really increase the access to care, whether it means us having mobile clinics into their communities, Or, I love Dr. Dieguez's idea of making it a policy to see patients by themselves, to really get as upfront and open of a history as possible, and frequent engagement in care. Trust is not something that develops overnight. We have to earn trust, and that comes from us being vulnerable enough to have open and honest conversations about sex, about difficulties in managing financial pressures, domestic pressures with partners. It starts with us being willing to have the conversation.
Well, I thank you both for your time, and I think we are poised to hopefully do better by our patients, to do great things going forward, and hopefully make a dent in the situation with HIV infection, treatment, prevention in women and girls in Miami-Dade County. Thank you so much, and thank you to the audience for spending some time with us today.